Good evening to our viewers and welcome to the National Crime Prevention webinar series, Keeping Our Communities and Families Safe. To those of you who have been with us from the inception, thank you for staying with us. Today we'll be discussing taking care of the elderly and persons with disabilities. This is our 5th of 8 sessions and we continue every Tuesday and Wednesday until the 8th of July. Please visit our social media platforms at NCPP TNT for further details and to register. I am Major Retired Cheryl Richardson, the National Coordinator for the National Crime Prevention Program. The National Crime Prevention Program is designed to engage, educate, and empower persons to partner with each other in order to achieve safer and more resilient communities, as well as an improved quality of life. We envisage that empowerment is a key factor in creating a national culture of crime prevention. As we all know, the elderly and persons with disabilities are amongst the most vulnerable in society, and as such, today's topic is on taking care of the elderly and persons with disabilities. This is an important matter that needs to be continuously addressed. The elderly have served and helped to build the foundation of our society today. This group carries with them a wealth of experience and knowledge which society can glean from. During this time of their golden years, they require express love, support, and appreciation. In addition, as we focus on persons with disabilities, we must understand the importance of caring for everyone, no matter their circumstance. These citizens positively contribute to our society in many ways, and as such, it is important that we continue to value and respect them. To expound on this very important topic today is Dr. Jennifer Rouse. Dr. Rouse is a gerontologist by profession and the former director of the Division of Aging in the Ministry of Social Development and Family Services. Dr. Rouse is the holder of a double major in social work and Africana studies. She graduated with a baccalaureate degree. Dr. Rouse is also the holder of a master's degree in policy science with the area of concentration in aging issues. She attained a doctorate in public policy and aging. Her doctoral thesis is entitled A Case Study in Aging Policy in Trinidad and Tobago, the role of interest groups in defining new policy initiatives. I encourage you, our viewers, to post your questions and comments during the session. And at the end, time permitting, we would seek to answer most of them. Note, accurate and relevant information is vital when taking care of the elderly and persons with disabilities. You can be part of the solution. Stay tuned. We cannot do it alone, but we can do it together. We will now hear from Dr. Rouse.
And a pleasant evening to everyone, to our viewers. First, I want to thank profusely the Ministry of National Security, National Crime Prevention Program for hosting such a seminar, because this is so very important for the community, for families, for the society to know what is happening. And then indirectly, the pandemic that has forced us to be locked in has brought so many families together for a long time, and we now have to look at how we relate. All our relational issues now have come to the fore. So without further ado, you have already been introduced and heard what the theme is for this topic, which is taking care of the elderly and persons with disabilities. And we have a PowerPoint presentation which will facilitate those of you who prefer a visual of some statistics that I will have. I am not overwhelming you with too many figures, but you need to have a context within which we are going to fit all of these elements of the various slides, as you will see. So I now go to the PowerPoint presentation for the first slide, and we will take it from there. So the situational analysis of what we look like in this elder population. Trinidad and Tobago, what the United Nations, they have designed that the baseline with the two populations, I should establish this first because we are dealing both with the elderly and persons with disability. Now the statistics will show that there's a baseline age which defines what is an older person, and that is 60 years and over. As a result of which, you can see from the slide that the last census, which was done in 2010, showed that we were at that point 13.4%. But the next point on that slide also shows by 2025, which is in 5 years' time, we should be at 17.7%. So now that we are here in 2020, we cannot still be at 13.4%. So I made an approximate that we should be around 15.4%, nearer to 16. And therefore, in numbers, that will amount to almost 215,000 older persons, 600 to be exact. And look at where we are expected to reach by 2050. 30.1%, all things being equal, because the whole globe is aging, and we have to understand how this is, what are the factors bringing this into being. So you can also see now that one of the things that this has brought to bear is that the existing institutional arrangements that are there are pretty untenable, because it is an exponential growth rate that at which these seniors are even retiring, and the life expectancy is much longer, and the lifespan, I should say, is now 120 for older person. So for the persons with disability now, there is no baseline by age. You can be born with disabilities, you can have temporary disabilities, and then you can have acquired disabilities through later years. So as a result, there is no one size fits all. So even though we may be have similar, we may be in similar, we have a great deal of similarities, we are similar but yet different. So we go to the next slide. Now, when we look at these dynamics, those dynamics say a lot. What it is that those persons who are considered dependents for the society, those persons who are under 15, over 65 being now you are in retirement. So these are not in the world of work. They are the dependents to be supported by those persons who are in the working age category, that is 16 to 64. Now, what we see happening here, because of the change and the impact of the family structure, and you will see that fertility is now much lower. The dependency ratio in about 10 years ago was like 9.7, 9 to 7 in terms of those dependents on persons who were in the work age group. But look at what is happening by 2050. These are the persons whose taxes and all the charges that are going towards the consolidated fund are to support the pensioners. But look at the ratio and proportion in terms of how the lower fertility rate is affecting the work world, the workforce. So as a result, what we are seeing is that the dependency ratio is now becoming a bit flawed, and I will explain that later on another slide. Then we have another interesting phenomenon here with the parent support ratio. Because we are living longer, with the lifespan being 120, we have almost 200 centenarians, as a result of which the majority of whom are female. But look what that ratio is saying. We have here where we have those persons aged 50 to 64 who are still working, The only reason they may not be is if they took like early retirement. But they are the age 50 to 64 with their families, but their aged parents are still alive. So those who are in the old category of 85 and over, look at the ratio where that has gone from 4 to 8 and is expected to go to 19 to 3. So there is that informal community-based support that is the norm, not only in Trinidad and Tobago, but is in the Caribbean, where we look to the family first and we have our elders living with us. But we will see how the shift in the family structure has impacted on that. So I went to the dynamics of population aging. What brings this phenomenon, population aging, which has now become a global phenomenon? There are 3 factors that impact it. Low fertility, which means families have shrunk. They are no longer the extended family, but they are now more nuclear and single parent and single-headed households. So you have low fertility, you have low mortality, which means that you are living longer. And net migration is important here for those who have emigrated in terms of some of our professionals, etc. And those who are immigrants coming in most times from the Caribbean regions. That net migration figure is a bit nebulous. Not even in the Central Statistical Office can they pinpoint and give you actual figures of what we are looking like, because some who leave tend to stay abroad, and that is having an impact again. And as we know, what we should mention here in the migration, we have the barrel children that came out of this, where when they migrated, and some did for greener pastures, they would send down their remittances and the barrel with supplies so that that could supplement the grandparents, who most times are the relatives that are taking care of those young ones that they might have left behind. So there you go again. When you look further down on that slide, you will see now that grandparents are parenting once more. But with the recession and all of that that has hit America and the UK and Canada, those barrels have reduced significantly, as well as the quantum of the remittances. So we have to understand what is happening to the economic support that was given there. That is not the same. Now we have, as you see, the increasing number of nonagenarians, those in their 90s, and then the centenarians. I'm not going to read each line verbatim, but I just highlight the things that we need to pay particular attention to. So what we are seeing here is loneliness, is something that is a major issue for our elderly. Now, when Dr. Joan Rawlins had done a research study in about 2006 or 2008, she had done this study, taken about 547 respondents or informants, and looked at the family, the households that these older persons were in. And out of these 547 respondents, 16% of the elders that she interviewed complained of being lonely. But what was significant in what they said, they were not living alone. And that is the worst kind of loneliness, because it means you are in a household with people who are not engaging, they are not socializing with you, so you almost feel like a fixture in the household, and there's no attention, there's no stimulation. And so you feel as if sometimes maybe that feeling of being an imposition or a burden. And that is the loneliness that is oftentimes lead them into depression, which is not a good thing, not a Caribbean thing, because of the kind of way we used to live. Especially knowing that so often our elders who lived in the household, like mine did, I had a matriarch, my mother's mother lived with us, and she was the matriarch of the household, as opposed to my mother, and my father was the patriarch. So they had very clear lines of authority. Now we also see that 16% of the patients at the psychiatric hospital who are aged over 60, because mental illness again, still has taboo. And we still find that those persons who are in those institutions for mental illness, they are not, there's no geriatrician per se in terms of the numbers that we would expect to treat with these patients, and they are often left behind or just absorbed as part of all the other population, the rest of the population that is in the St. Anne Psychiatric Hospital. There is a geriatric ward that we have in the St. James Medical Complex, which is the gerontological ward, but in the St. Anne's, they deal with mental illness specifically. And we also have the Alzheimer's Association, which gives support for those who are in dementia, and we will see that later on. Now, important to note is that feminization of poverty, which is a term that was coined in America and in the gerontological texts. Because our women, especially Caribbean women, we still tend to marry men who are older than we are. Older than women are, their female counterpart. And you can look at that and see what the life expectancy average is. 81 years for women and 78 for men. So oftentimes, this myth, as we think it is, that the men are the breadwinners, and so often some of these women who are in the informal network of the world of work end up being almost impoverished when these men die, and especially if they did not leave like insurance companies, they were not in the NIS because they were self-employed, and all these other exigencies, which will place her totally at a disadvantage. We will flesh that out a little more in later slides, but that term, that's how it was coined, because it is so often on the woman that is placed in this unfortunate circumstance. What we also see is the aging persons with disability. Because when they are born with disability, or even may acquire disability as a child, the parents are vital, they have the energy, they can shower them, especially if they are persons with disabilities with special needs, which means they may have more than one disability, which is possible. And the parents are able to be their main caregivers, accompanying them where they have to go, being always there for them. And there are some who they have to do all the activities of daily living, giving them their shower, feeding them, etc. But then what happens is, and this is where the synergies begin to coalesce, where the parents are aged and the persons with disabilities are no longer children, they are now adults. We have where some of them are now in their 50s and their parents are in their late 70s and going in 80s. And their energy, their life force, they can't do it. Some even suffer with back problems because over the years, as the child grew and got heavier, they just went along with the same style of caring, but not understanding the toll that it was taking on their physicality. So in their later years, you find that sometimes they are afflicted with rheumatoid arthritis or just arthritis, osteoarthritis. And it brings in now those psychosocial elements because they feel fear that if something happens to them, God forbid, what will become of this adult child who they have been their sole caregiver all the life, except for if they used to take them to school, like we have the Lady Hojoy or the Princess Elizabeth, but they worry a lot. Who will take care if they die before the child? And that is something we need to flag because it is real. Therefore, it leads to the next term that we need to have more long-term residential care facilities because we don't have enough. What we call the home for the aged is a dying breed, as they say. That's not the model of care that we are taking forward in this 21st century, not for the baby boomers who are now retiring. And I should add that the baby boomers, who are those of us born between 1946 and 64, the last cohort will be retiring in 2024. And that means retirees have been leaving to go out of the workforce from since 2006 to 2024. All of us would be off into retirement, except if we were in the world of contract, where it is more skills-based and our skills will be still needed in a fundamental way. And this increase in the non-communicable chronic diseases has replaced communicable diseases. But why put it there too? Now, remember, we are in a pandemic, and it is important to note that here, because the first target group that was mentioned with the coronavirus was the elderly, but not just the elderly, the ones who had pre-existing health conditions and underlying health conditions. And all these chronic non-communicable diseases are lifestyle. So it means if you have, and we also see another important point where they have what is called comorbidities. It's more than one. So one old person may have hypertension, may have high blood pressure and diabetes, or osteoporosis and arthritis and something else, and maybe early dementia. And these are the things that make them more vulnerable to the pandemic. To the next slide. So these are some of the initiatives that were established by the government over the years. We have currently a division of aging, of course, of which I was the director, and there's also a national aging policy, which came into being in 2007. That's when it was launched. The Disability Affairs Unit is also there. Both those divisions are in the Ministry of Social Development and now called Family Services. They also have the National Policy for Persons with Disability, which was also launched in 2006. So they were in 2006, the aging policy was 2007, but you realize we are in 2020. So both those policies have to be reviewed, revised. And I believe when I left the division in 2018, the national policy for the persons with disabilities was revised. So there's a draft policy that is revised, but not the aging policy just yet. There's also the Geriatric Adolescent Partnership Program, which deals with training of young people between the ages of 17 to 35 that will go to the homes. This is the private homes, and perform the basic duties of activities of daily living, make sure that that older person has not only the companionship, but has their meals, medication, and generally is in good state of cleanliness, that they make sure that they have a bath and general companionship and activities to stimulate them while they're there. But we have to also recognize that in the Geriatric Adolescent Partnership Program, it is heavily oversubscribed by females. And as a result, there is a gender skew there, where we definitely need male caregivers coming to the fore, because it makes a better partnership when we have the elderly male that would like to have the same companionship, but he's no longer, he may be widowed, he may be never married, and now requires help because of the dependency that comes with infirmity. And the slide will show you the various programs and grants and centers that we have listed there, so we don't have to go through each line. Those are mostly from the Ministry of Health, those dealing with community care program and wellness centers, the mobile health clinic, and the health education. What we will need to flag though is when we come to another slide, when we deal with pensions, with the NIS and the sustainability of these grants. That will be in another slide. But these are the initiatives that have been put in place for these two groups. And you want to promote social participation. So United Nations has these 3 established international days where you kind of make the population aware and sensitized that this exists and the reason behind it. So International Day of Older Persons is observed every October 1st, and this was initiated in 1999 by the United Nations. World Elder Abuse Awareness Day was launched in 2006, and that was launched by a small group of women who came from Australia, and they had seen the spike that was occurring in elder abuse, which is a travesty by any means to have such a day to observe. But they started off very small, and they lobbied and lobbied on the ground until they approached the United Nations and said, look, we have noticed that the rate at which we are aging, especially in the developing countries, commensurate with the rate at which we are increasing in growth numbers, we are seeing this commensurate spike in elder abuse and coming in all the various forms. And that's how the International Network for the Prevention of Elder Abuse came into being, and United Nations gave it the label now World Elder Abuse Awareness Day. And that is observed every June 15th. And then for persons with disability, annually, they have December 3rd as their day. And both the International Days for older persons and for persons with disability are always have a theme. So when you go on Google, each year by about August or so, you will be able to find what the theme is that will guide what we do differently or we try to do in improving the quality of life for our seniors. We have now an NGO. It is our largest aging advocate. Trinidad and Tobago, they used to be for retired persons. I still put the word there, but they usually like to be known as the Trinidad and Tobago Association of Responsible Persons. And they are about 35,000 to 40,000 registered persons. Initially, when it was opened and launched in 1993, they started off, yes, because, slowly, and eventually came and was recently celebrated there in 2018. They celebrated their 25th anniversary, and now they have before they started taking in their members from the age of 60. But because now they have so many seniors who are taking even early retirement, they saw the need that they needed now to have more persons in at a younger age. So it has they are eligible from 50 years and over. And the TAP is serving a great function in terms of really making them come out from and participating with social inclusion, which is one of the priority areas of action in the aging policy, that we need to keep our seniors socially included, as well as it is also one of the action areas in the policy on disabilities, persons with disabilities, because neither of these groups wants to be exclusive, where you only do things for them, and they always have to stand out as a group, only socializing amongst themselves. They want to mix and mingle with everybody. So therefore, it immediately brings to bear an intergenerational matrix that we need to be working towards. We have the National Center for Persons with Disabilities, which is in the South area, doing phenomenal work, run by Dr. Beverly Beckles, and she was the one that founded it and initiated. We have numerous retirees associations. Now, the advantage of TAP is that it is a citizens organization. So you do not have to be a member based on what your religion is or what your profession is. And so you find many members who are in other retiree associations that are based and have parameters by which they are founded, can also be members of TAP. So there's a kind of cross current and cross fertilization that happens between all of them. And then you saw the list there with other NGOs that exist for persons with disability, because the persons with disability have a consortium of disability organization, which is almost like an umbrella body with representation from the various groups. Well, like everything, it must have challenges. And here, aging. Remember, aging is about persons who are considered old. And then we have persons with disability who are considered differently abled. We use it in a positive way, but sometimes both groups. We have a countervailing force that is real with persons who are over the age of 60 called ageism. It's a term that was coined by Professor Robert Butler. And when he coined the phrase, he noticed that there was this prejudicial, pejorative way in which older persons were labeled. Some were they were almost profiled as being miserable, wrinkled and no longer attractive, forgetful. And you would even see, like in the media and in the films, like movies, they make fun of them, and in movies and comedy. And that is not how it really is supposed to be. And then when we even look at, you could be, what ageism also fosters is that once you are in the world of work and you are an earner as well as a producer of labor, you are considered an asset, especially if it is a skill that is required in a particular agency. But the moment you go into retirement in the real sense, you hear terms like you are going out to pasture, you are now in the waving gallery. And suddenly, from an economic perspective, you become a burden to the state because of pension, and you have the non-contributory pension. Now you will notice there is another line there about the sustainability of this, because the pension that is the monthly pensioners from the public sector, which is the largest employer, they fall under the Pension Act of 1937. And that act was framed and crafted when communicable diseases were the order of the day. Mortality and morbidity was high. Families were large. And so you weren't even expected to live past 60, even though the retirement age was 60. And so the pension was non-contributory. Well, that has remained so in the public sector. But now the demographic transition has brought about a flip where you can have a pension until death, but the mandatory age of retirement has remained at 60. So you are now living longer post-retirement years than sometimes the years you have worked. As a result of which, how sustainable is the pension? Because it's like what they call an age wave. That's what the title of one book, and also the age tsunami. Because all of these retirees are going out of the work world and entitled to these pensions, whether contributing or not. And we also have the NIS, which is the National Insurance Board, and the National Insurance telling us already from the 10th actuarial report, which just recently was published, that this is not going to be sustainable past 2030 unless we freeze the pension benefit from now, increase the retirement age to maybe 67 or more, and raise the contributions, increase the contributions, otherwise it is not going to be sustainable. This is critical. And so you saw in the first line where now in policy, for you to know what resources need to be allocated to any particular target group, you need to define what is your problem. What is the issue here? And when we look at Trinidad and Tobago, just us, Trinidad is different to Tobago in terms of its homogeneous, well, Trinidad is heterogeneous and Tobago is more homogeneous, and Tobago being more Afrocentric. Trinidad is plural. And so here we have a sort of conundrum here, where you have to study now, how are we going, how do we define this aging issue? Is it political? Yes, it is, because you need the votes. As older persons, they are very diligent when it comes to the voting and how they won the franchise. Is it socio? Yes, it is. We just spoke about social inclusion. They are an intrinsic part of the society and a resource. because most times these seniors have invested in the biggest capital investment, which is their house or property or land. And that ends up being to carry on to future generations, even though we try to label them as a burden. But that is, it's an asset that is convertible into cash. And yes, it is an economic issue. It is also a cultural issue, how we treat with our seniors in this plural matrix. And then more than that, it is a moral issue and a spiritual issue. So all together, it is all of the above. And something that a phenomenon that has occurred that has never occurred in the world before is that we now have 5 generations living together, and not just living together, but working together. So we have the traditionalists, which would be the parents of the baby boomers. So they were in the 1900s up to 1944. And then you have the baby boomers from 46 to 64. Then you have Generation X from 65 to 84. And then you have Generation Y from 85 to 95. And after that, you have your millennial Generation Z and counting. All of us are in the workplace together because of the world of contract work, which has now been a parallel system of work going alongside the permanent staff work, which has caused its own challenges. So as you can see, what we need data on community profiles so that we will know where people are, where people live, where are the persons that are the elders and shut-ins, and where are the persons with disability, so that we can see for sure what kind of conditions that they are living in and how they are making do, as we could see. And we need to be attracting more persons into the profession, because there's a paucity of geriatricians. Because when we were born, the baby boomers, we ushered in pediatricians to deal with baby illnesses and childhood illnesses. Well, now we don't have the commensurate amount in proportionate numbers to serve us now in our older years. This particular slide, more than the recommendations, would be easy to figure out because you would have seen the challenges. But this particular file, I want to finish, almost round up with, because I'm looking at my time already. And we have I said by half an hour, because we started almost at 1:15. This is an epidemiological profile of what is the working age. Now remember, earlier slide, we dealt with the dependency ratio, which is that those who are not in the work world, below 15 and over 65, are dependent on the wage earners who are between 16 and 64 to provide financial, social, psychosocial support to the older persons. Well, look at what's happening here. These working people who have their own families, they are trying to juggle work-life balance and not doing a very good job of it. Because what some of the epidemiologists have said is that the rate at which change is happening is so fast that it is adding a different level of stress on these young people. These are the millennials who are in their 30s and 40s. And that is something we have to flag, because they are doing multiple roles simultaneously, like caregiver, parent, worker, and darting in, out, that's why the pandemic had to slow everything down, bring some kind of stability, because people were moving at a frenetic pace. But the important point to note is the second one, where inside of this population that is working, age 16 to 64, look at what's going on. Now, I want us to connect the dots here, especially to understand why today was how it was, with some chaos that was going on in our streets. We have people with the multiple chronic illnesses. We have homicide, which is affecting mainly those who are age 15 to 44. HIV/AIDS, and the homicide is largely male, Afro-male. HIV/AIDS, 15 to 44, largely female. Vehicular deaths and disabilities. Usually the vehicular deaths are printed in the newspaper. You don't ever hear of the ones that survive, but will have permanent disabilities. And who takes care of them? But they are now with the family. And these vehicular deaths are usually more endo males. Teenage pregnancies, who still have to live home. This is where the grandparents parenting. I want you all to walk this with me. Mental disorders. We now have, when even we are interviewing people for a job, to do psychometric testing because they could pass the exams. That's an easy thing to do. But how stable are they? How do we know if they can handle the stress of multitasking? Because when you have a degree, especially an advanced degree, that is what is expected of you. But if you don't have the capacity to do it, even though your CV looks very grand, you are not stable enough to handle the level of work. And that is being seen across the board. Divorce is now 50%. That's the rate of divorce. And here we have our unemployment, but we also have underemployment, which is also called the working poor. And with this pandemic, with some who had to go home and have their salaries reduced or no salary at all, or some may not even get back their jobs, they might have been the sole breadwinner and getting a little support from granny or grandpa pension, who might not have got his pension on time. What is going on there? So that could be the genesis of elder abuse right there in the household, because of the stress and the tension of not having that support financially, even though you may have to ask for a salary grant that is being offered, but not all will be received at the time that they would like it. So that question of homelessness, drug abuse, incarceration, largely the Afro male, all these are between the ages of 15 to 44, largely. So these are your potential caregivers of the older persons. So that's when I told you earlier, the dependency ratio is flawed, because when they should have been supporting the older ones and the not so old, very young ones, now you find granny and grandpa's pension has to take care of the children of those persons who are incarcerated, homeless, drug abuse, even the teenage pregnancies. Because some of these teenage pregnant mothers return to school. And where is the baby left? With granny. But sometimes we also have to know from these teenage pregnancies, granny now is 35. Granny is not 80 or 85. Granny too is working. So I want us to hold that. So right there, you can understand that's the crucible. That one slide, that one phrase, it's the crucible from which all the social unraveling is taking place. And therefore, the ill health, because the non-communicable chronic diseases come from lifestyle, that ill health with the kidney failure, and some of them, they having now Alzheimer's at a younger age and living longer with it. So even if it begins at a younger age, it is carrying on into your retirement. So you already were dependent before you reach retirement age, and that now you have to look to family or the church or the state from an earlier age than was expected or catered for. And here we have the abuse of the elderly, but this I don't have to talk to you, because you can see the slide with all the different numbers that you can call on for and the definition of what it means. But the other two slides give you the breakdown that I got from Crime and Problem Analysis branch, which does really good data. They really gave me from 2014, but I condensed it and just showed 2017 to 2020, which you will see on your screen. And those are the different kinds of serious crimes that are afflicted on our seniors. Then you also have the ones that are minor crimes, and then you have the domestic violence. All this is inflicted on our seniors and persons with disability. Don't ever forget them. And so we come on to our penultimate slide, and we should wrap up here, by which time I will be looking to see what any questions that are coming in from our viewers, where because of the kind of challenges we outlined, we need to have that more integrative, holistic healthcare service that will not make any of the two target groups feel in any way isolated or exclusive. And so here we have mental and social well-being for the elderly as part of the geriatric care. We need to have geriatric clinics. We do have patient care assistants in the hospital, but they need to have an expansion in the training to incorporate geriatric training, especially at accredited institutions, which exist already. The policies, as we said, both have to be revised, both policies for the aging and the persons with disability. And so we need to address healthcare in light of the aging population and our persons with disabilities becoming aged themselves. What is also a good group that can foster more assisted living facilities, which is the new brand name for retirement communities. It is one of the biggest industries in Canada and in the European countries of Switzerland and Denmark and Norway. And it is self-sufficient. Private sector can do this, as well as private sector and big, sustainable, robust NGOs, and maybe with partnerships with the government, but we need them. And if each prestige school, as we know, and it doesn't even have to be a prestige school, because I didn't like the label, but most of the high schools, the secondary schools and the alumni, they need to now seriously look at investing in retirement communities, better known as assisted living facilities, that they can do for their own and also by extension their community. And of course the assistive devices, and we need more volunteerism because that comes with the retirees when they do age. Promote more strengthening of the family, and a program that has hit off quite well in America where seniors caring for seniors, because you have the young old who are aged 60 to 74. You have the old who are 75 to 84, and you have the oldest old who are over 85. And there's a nice synergy with the young old who are 60 to 74 dealing with the Alzheimer's patients who are over 85. And they make a really good, very relational kind of synergy that works for both of them. So this is my final slide, and I hope that I didn't go too fast and that I would invite any of the viewers now to ask questions, and yes, I do have. One of the questions I have, how can the high rate of unemployment in Trinidad and Tobago and how can the high rate of unemployment in Trinidad and Tobago and financial dependency affect the elderly? Because what happens oftentimes, the elder ends up being not just the beneficiary, but almost the financier, helping from their pension, because there's quite a number of them get both the NIS pension and the social welfare, or they get their national insurance and their monthly pension, and that is what is bringing the stress. So how can the high rate of the unemployment and the financial dependency affect the elderly? That's how it's affecting them, because they have to take out of their own little money sometimes. Now, what some have also had to do, they have had to refinance. This is some who have retired now and mortgaged because they own their house. Their house is their biggest asset. And some have had to refinance their house. That comes like having a whole new mortgage on your house again in order to help with the ones who are now out of employment. And so, and I hope I've answered that question, which is what is happening. I'm giving you real life answers to what the situation is. Some even elders go and do extra work. They do cake making and they do little things that they can sell, but some are under considerable stress. The mental capacity of the elders, this is Question number 2, the mental capacity of the elderly can create a strain on the support systems. How can family members provide the relevant support needed? Now, this is a critical area, because when we talk about the mental capacity, now not all elderly people, mental degeneracy is not a symptom of aging. We could forget, yes, and whatever, but there are some. I spoke of one earlier today, Louise Horn, who was a senator, and she's now 109 or 10, and her mental acuity is sharp as a tack, you know, but your physicality can go and break down. But when they are becoming dementia in the Alzheimer's, which is a degenerative ailment over time, and the whole persona, the whole personality changes, and it becomes a real strain. Now, when you use the word strain on the support systems, most times it is the first family members that have to be the ones taking care of them. If it is a marriage, it could be the spouse. But it's a psychosocial impact it has on the support system, because the person who is wearing down, and this is where the word respite care is critical here. We have 169 plus homes for the aged in Trinidad and Tobago. You will have the numbers there that you saw. You can call into the division to know where care, which homes can treat with care. You now, as the daughter, adult daughter or son, you feel a burden of guilt to know how could you place your mother into a home, because there's another myth out there that these homes are so deplorable that if you even think of putting your parent there, they're going to die. And the parent, him or herself, thinks the same, that you will be abandoning them. So it is both, it is a two-way, bi-directional burden on both of you. That's where you need to take respite care. You need a break as a caregiver, especially the primary one. And there are homes where you can ask if they can keep your older person, your older relative for 2 weeks or 3 weeks or a month, and you take a break. Because I try to impress this on caregivers. You cannot give what you do not have. Do not try to play martyr, where you just know, well, you know, you owe it to the parents, you owe it to the spouse, you have to. That self-talk is not going to do you any good, because you are dying. And oftentimes the caregiver does die before the older person, because you're putting all out, you're bleeding. And that is not health. That is not healthy health. And Maslow, the psychologist Abraham Maslow, said, we have to understand there is such a thing as healthy selfishness, where you have to step back. It's now called emotional intelligence, and say, my emotional bank is in overdraft, and I have to step back and bring it back into the black. Otherwise, I will be starting now with unintentional elder abuse by shouting and bawling and being irritated because of the mental breakdown of the senior that is in front of you, but you still love them. But it is your physicality that is just screaming for help. And you have to let go at that point and look for respite care. If an older person lives alone, what are some security measures that can be undertaken? Now, what we have seen and continue to see is that most of our seniors who live alone are female, predominantly, and because of their sheer numbers. Now, what Tobago has done, which is something we need to replicate here, there's a lanyard that you can hang around. It's called a security alarm. That once you live alone, you should have that. You keep it around your neck, and it has a button. And it is a device that it's when you press it, if you fell and you can't get up, or if you might have been in the bathroom and you after sitting or in the bathtub, you can't move. You can have that always near to you, and it is connected to all the primary telephone numbers, so that once you press it, you will never get a busy or a voicemail. So once you get one and it rings out, you go into the next number. It flips into the next number until somebody comes. So it is up to you to know who to entrust these numbers to. And some of you, it will be your neighbors and the one or somebody from your church or somebody that a school friend that you're still in communication with. Those are the numbers that you choose because trust is involved here. And it is always good, again with the trust, to have a duplicate key. If even not the front door, but at least the back door or side door that they can gain entrance. And as I say that, it also brings me back to the point of burglar proof. Some of us go and place burglar proof in for the burglar, and you are only looking at who you are keeping out, not understanding you locking yourself in and not having a flap door. You cannot have firm burglar proof, and that's how a pensioner died the other day. They couldn't get in. The fire brigade reached on time, but they couldn't get in because even though they knocked down the door, he also had a grill door on the inside. And so you need to take those measures. Also, where you place your keys. Now, you're not going to put it for if the thief comes in the front door or somebody coming to attack you. You have all on display. But you place it at a vantage point where you know where every key is. And so you can, at a moment's notice, have one close to you. Always keep a phone near to your bed head or your little night table, so that you know and make sure it's charged. It has money. And I try encouraging some of our seniors, it is more economical to pay postpaid on a mobile than prepaid. Because with prepaid, you can run out of money. With postpaid, you pay less, considerably less when you check it, but you don't run out of if you have to make a call. And try and get a phone that is comfortable for you to use, not something that is too overly sophisticated. And a main thing too is don't be isolated, and don't be regimented in doing the same thing the same way every day. You get up, you go out to maybe get some sun at the same time. You will read your newspapers at the same time. You go to the grocery on the same day, and you go out for your pension, especially because you are being marked. It's an easy way to be a target. So you have to change up your pattern of doing things. And that's why the ministry even advanced direct deposit for your pension, so that you can not only go on the first of the month, but you can go anytime and have it. Because once you go the same day, the person who is the pariah looking on will know that you're going to encash that, and they will be following you. And always line with some young people, even if it's from your church or your nephews or your nieces, because some of the older persons who live alone never married. So many of them don't have an offspring. But you have to get with the program and get somebody that is young enough to keep you stimulated, and they will visit, and they can take you out sometimes, or you invite them for lunch and whatever, because there's a nice synergy even with young children. And I said it on another program where they also come in handy, that if they build a sufficiently strong bond with you that you trust them, they could end up being the executor or executrix of your will, that you know this person will carry out your bequest to the letter because of the trust and honesty that was established between both of you. Does the Ministry of Social Development and Family Services lobby for job opportunities for the persons with disability? The word lobby, that would not, well, yes and no, because most times lobbying, and when you talk about lobbying, you mean like advocacy, that is built into having the Disability Affairs Unit. And in the Disability Affairs Unit, they have when I left, they had 2 staff, because it's a small unit, and they have 2 staff who have disabilities themselves. One is both of them are visually impaired in different ways. And I remember when I was at the Division of Aging, I even employed a guy who was deaf, and he could lip read, The only thing I didn't put him on was the telephone, but he turned out to be one of the most proficient typists. You should see the speed at which he typed, and I gave him things to type. And he could, he speaks with a slur, but anybody seeing him wouldn't know that he's deaf. And it is incumbent on the leadership of the ministry and the person in charge of the particular unit that would do that kind of advocacy for giving opportunities for persons with disabilities. And now there's a committee that is working on the Center for Disabilities in Carlson Field and getting a new name for it, and that would have the amenities, and so that will not only be for persons to serve persons with disability, but there will also be opportunities for persons with disabilities to be employed there, because persons with disability like to see others within their own group that are active, and one is on that very committee. I think her name is Shamla. And some of you may know her. She does she's doing her PhD, and she's a special needs with cerebral palsy in a wheelchair. And she did her bachelor's and master's. Her body moves all the time, and sometimes you see her on TTT. Brilliant, brilliant person, and a wonderful personality. So through that, the ministry has outreach programs that they do from time to time, and it's called PIES, public education and so forth, and they go out to rural, remote areas, and they spread the word of what services they have and job opportunities. One of the key things that when I left, they were looking at is their buildings, because where the ministry has its buildings and local board offices, some of them, the beneficiaries who like seniors and persons with disabilities, where they have to go for the grants, they noticed some of them were not, it wasn't wheelchair accessible, didn't have ramps, didn't have amenities where that doorways. And so when I was leaving, that was the last drive that they were looking at, because there were workshops held on accessibility based on Ministry of Planning that was looking at that to deal with accessibility to all public buildings. So it would not only be for the Ministry of Social Development, but it would be across the board of public service and public sector, that all ministries, and of course you would notice at the government campus, that they all have ramps and railings, and everywhere the doors, how they open, toilets with the lower tap. So things are happening. At least they are a lot more advanced than when I just started in 2003. What are some of the experiences persons with disabilities had during the COVID-19? Now, I'm not in a position here to have those statistics of how they dealt with it, how they are dealing with it. And to be honest, I really prefer when questions like this are posed, that you speak really to somebody who has a disability. Because I always, we have able-bodied persons who speak on their behalf. Now, in the United Nations, when the Division of Aging was established, it was established coming out of the Madrid International Plan of Action, which was United Nations had the World Assembly, a General World Assembly on Aging. And it is from that second World Assembly that our ministry had a representative, our government had a representative who signed on that we will be part of that. And one of the things that was documented in that Madrid International Plan was that the best persons who know what older persons need are older persons themselves. So it is not that I want to skirt this question, but because of the wide spectrum of disabilities that exist in Trinidad, you have not only just the deaf, but you have the hearing impaired. You have the visually impaired, you have the blind. You have the autistic, you have the cerebral palsy, you have the dyslexic, you have those with special needs that go to Lady Hojoy and Princess Elizabeth. And then you have what is called the invisible disabilities. These is like deaf. You would know if I were deaf, and because I'm lip reading, only when you see a signer or how I speak. And our Archbishop Gordon is dyslexic. And so you have now the mental aspect of disability, learning disabilities, which are invisible. And so for that particular question, how they have really experienced it, I am very curious myself to know. And I think the best person who that could be lodged with is either the consortium itself of disability organizations or NCPD, the National Center for Persons with Disability, and good that one is in the south and one is in the north, because that's what I meant when in my slide I said we need to have data on community profiles, because when you have community profiles, you know where everybody lives. And remember, the statistics I had used were from the 2010 census, because the census, population census, is done every 10 years. So 2020, it was due to be another population, and guess what? The pandemic came. So it means that has thrown us a whole year behind, because nobody could go out and do field work in this just yet to establish what is happening out there. So that is a very silent area, a very quiet area in terms of how are they really faring and how are they making out, and the numbers. And that's the advantage of having ministries collaborate and really go out in the field door to door to know what's going on. Another question was, are there any plans to build government-assisted elderly homes where caregiving fees would not be exorbitant as is now with the local private homes? Now we have, in that 169 plus homes, there are 7 homes, used to be 9, but there are 7 homes that are what you call subvented. They used to be poor houses in the 1950s, and they were inherited. The government took them over because, you know, the persons who were the residents of those homes were indigent, and some of them didn't even have relatives, and they had nobody to take care of them. And so instead of having that stigma of just a poor house, they were changed, the name was changed to Homes for the Aged. And they are in rural and remote areas, but they get a subvention. So it is a good idea to have governments build those homes. Now, what they do right now through the HDC, and that is the Ministry of Housing, every housing development, and I hope that still exists, but every housing development is supposed to apportion 5% of the housing stock to persons with disability and another 5% to persons who are elderly. And that is because that's where the similarities come in now in terms of what these amenities need to be for those particular houses. Because they must have ramps, both target groups must have ramps with railings, wide doors for wheelchair access, non-skid floors, lighting must be white light, more energy given than heat, no carpeting. The colors must be ergonomically designed where they're on the eyesight and what have you. And where they have to reach for the toilet and bath, there needs to be a wide door for wheelchair access. You see some of them in some of our food courts. You must have that wide door for wheelchair access. There must be no steps. And even like when they have to do groceries or so, they must be able to come up that ramp easily. But all of these, and if even it shouldn't be like air conditioned, they should have, you know, well ventilated houses, not too low, not too high. But the whole question of now building these government assisted homes, well, money now, it has to be now part of the plan of what houses are being built as we speak. But that 5% apportionment still stands. And then what the government does do is if persons have homes already, they also help with renovation and refurbishment through self-help. You have the self-help part of government that gives the material, and then you get the labor. There's also the home improvement grants that you can get for your home. And even in HEC, I don't know if it still exists, but they do have a program where they call the Granny Suites. And they use Granny there technically, because I had to point out to them that Granny is pretty young now, so be careful who you're referring to. But you can add on an annex if you want your older person to live near to you, where you can visit and they don't feel isolated and alone. But you can add on to your house an annex for Granny or Grandpa to be close by, and you get it as a soft loan. So that is called the Granny Suite. What they have also established too in HTC, that they would have a longer time to pay off the mortgage. So if even the mortgage ends when you retire, you can continue paying until 65 if you retire at 60. So all these are some little tweaks and tweaks that they make to the policies and the laws that will facilitate this group. But I think just to build, that's why I put it out there with the assisted living facilities, that private sector should go into it in a kind of a partnership with the government, that they should keep a cap on what the kind of cost is, because they could be very exorbitant. They've just left it totally up to the private, because we do have some that are very high and they're more class oriented, they're very gated, and this is for a particular class and income based. But I hear your point. But now with this pandemic, you know what that has caused. We are in a deficit budget, so it is a wonderful idea, but not for the short term. It may be for the long term. What may be some solutions to minimize some of the issues of aging? Well, that term that you use there with the issues of aging are vast. Now, I just touched that aging is a political, socio-economic issue, but I have a whole 20-slide presentation just on the socio-economic implications of aging. So when you speak of what are some of the solutions to minimize some of the issues, part of it is that at the top of my head, we can think of even keeping some of the elders vital. This whole question of you have no more use, you're going out to pasture, you're no longer productive. No, we need some of their experiential learning. They are also historians, and therefore in that part of social inclusion, in that part of continuing education, because abroad there was a course where if seniors, especially grandparents who want to return to school, if they want to retool, they need to have a more affordable fee that they can use at any of the universities that we have to do specially designed degree programs or diploma or certificate programs for them that will keep them feeling vital. Because when I went to study, I started at 44. That's the age I went to change my whole career 360 degrees. I left BWIA, I was always in the airlines for 27 years, and that's when I went to study at 44. And your whole way of learning is different, because you're not going into it to just go and get the A, you must have a 4.0. No, you're more relaxed and you're more looking forward to the joy of learning. So in so doing, you can now more comfortably do what you like, what you have always wanted to do, and bring that essence, your essence to it, to give it that life. And then you can be a wage earner from that very skill that you have now seen has come to make you viable and remove you from being overly dependent on state resources. But that is a big question. That there are some solutions to minimize some of the issues, because you also have a whole industry called the silver industry, where you can, if you are a lawyer, you can be doing will preparation and estate management. If you, because many times when we used to do the outreach programs, we would bring back in retirees to do financial planning. They would come in as guest presenters and you get paid. If you do batik or if you do anything that you had liked, if you want to do music therapy, if you are a musician, there are several ways, and this is an important point. I will end your question here. We have to understand, those of us who are now retirees, that based on how the different values have shifted in the millennials compared to us, we have to make sure we get more self-care, more cognizant of self-care, how we take care of ourselves. Do not live your life looking forward to depend on somebody to do it for you. You have to be responsible for your own self-care. And this is, I want to stress this, because this is going to reduce a whole lot of costs that you would incur down the road if you were just lax and just decide, well, it's me alone, so I will just eat crackers for meals, and then should I bathe today because, you know, I'm not going anywhere, and that becomes habitual until before you know it, you are in a depression, and then you just get self-neglect, and your teeth begin to decay, and you didn't go to the dentist, and your hearing and your eyesight, because cataract comes with aging, not glaucoma, but cataract. So we have to understand the millennials are not us. They are not us. They are not into all these regimens and things that we keep for sentimental values. No, no, no. So in another presentation, I can answer this in much more depth in terms of solutions to minimize some of the issues of aging. But in terms of physical aging, no anti-wrinkling cream or cosmetics will stop the aging on the physicality, but you can do your basic exercises, your diet, and walk, get your little morning sun, and things like that for vitamin D, and you can boost your immune system that way, and then fight the virus that is around. Could you please expand on the healthcare services available to homebound disabled persons in Trinidad? Expand on the healthcare services available to homebound. Now, you have persons in the GAP program, and you also have, yes, they are geriatric adolescent, but more than the GAP, you also have patient care assistants, which come from Ministry of Health. So sometimes with the homebound disabled person, if it is an elder, you can get someone from the geriatric adolescent from the GAP program, because they could be combined of elder over 60 and be homebound, and you can have someone. And there are persons who do it privately, but up to when I left the ministry, we never had a list really of persons where they were trusted, they were screened by any agency. You also have Trinidad and Tobago Registered Nurses Association. I think they're listed. You can also ask them if they do that service, because quite a number of them have retired and they have formed their association and they do house visits, and you can ask. And in those cases, when you employ a private person, you pay them by the hour. When you go through the ministry, whether it is patient care assistant or GAP, then it is means tested, and as a result it's subsidized, so that would be more affordable to you. But you can call the numbers that I showed you for the division, the OPIC number, and you can call also National Family Services. All of these can help in assisting, but it is more health care, so you're looking at Ministry of Health. Patient care assistants, that's what they are called. Are there any programs existing for the elderly to participate in during the day? Well, in my last incarnation many years, we used to have senior activity centers, but over time, because they were partnerships with the ministry, with the division and NGOs who operated these centers in 14 different localities. But over time, with the reduction in with money, funding, we could not continue the subvention at that time. But I got word that they are beginning to look at that program again. It's still on the board. But what they do, There are groups that are doing it quietly in the north, the east, the west, and south central, where small groups, some of them are from the churches, some are just from the district. I know Diego Martin has some. They have some that come to the Harvard Club and do their exercises. And then they also have those who go down to the boardwalk at Shagaramas to do, and the Federation Park pool to do aquatherapy. So there are places, there are programs existing, and what you can do, you can call the Division of Aging at the 800 OPIC 6742, and they can give, because they act as a referral facility, and they can link you with some of these services where you can still go out, because the centers used to operate on a grand scale, but now at a lesser scale, where I think you may even have to pay a little contribution of $40 so that you could pay an instructor who you may want to come and teach you dance and teach you Tai Chi, but they do have, but you just have to, you can call the division and they will link you with some of these services. Elderly Trinbagonians by nature want to remain in their own homes by choice. On average, how many persons live in care homes? Well, if care homes you mean in institutions, roughly in total about 3,000 between the 169 homes. About 3,000 live. So therefore, out of the total population of seniors, they only represent 0.001%. So it means 99.9% of our seniors live in the community. And so you are correct, because most of us want to remain in our own homes. So on average, how many persons live, and will assisted living facilities be more accessible and offer a preferred option? Very much so. Because we have one that is in Santa Cruz called the Villa, which is next to the fire station. And what the assisted living does, they operate on a sliding scale so that it is very ergonomic and very accessible. But what they do is, like, some rooms have no toilet and bath, and those are the ones that some of the Alzheimer's persons stay in, where they may have a half door that they can look out so that they can't wander and forget where they are going. Then you have some other rooms that are Jack and Jill, toilet and bath that's shared between two rooms, and then you have the suite. That's the model that we want more of, as well as retirement communities, because older people don't like to be in a compound with over like 150 people. If it could be like 50 people, but that's the model that we really want, and it is very attractive to every older person that I have spoken to, because some of them know them. They have sauna, swimming pool. They can do the social liming, as we call it. They have the bingo, the games, the TV. They go for gardening. They do gardening. It's really, really very holistic and user friendly for all of them. Can the GAP program include efficient training of caregivers? They do, right now they do training of caregivers according to, as I say, 17 to 35. Now, this is an important question too, because I already said we need some more males, but what we also hear from our old seniors, especially the ones who are more infirm, the ones who may be homebound, not necessarily just lying all day, but their movements are much more challenged. Those are the ones over 85. Most times they prefer persons, caregivers who are over the age of 40, and GAP trains 17 to 35. So I remember lobbying to say you need to start training some others, some older ones, and I think there's also a program in the ministry for a more mature person, a more mature but woman, but it's not specific to being caregivers. We need, and I had that on one of these slides, we need to have more robust training of caregivers at accredited institutions, because homes have to be licensed so that you can hold people to account for any fracture, or if something happens to any older person, to know that they know what they're doing. Right now, the homes vary. You can have some that they cannot deal with persons with Alzheimer's because they don't have the proper training. They have some that are only trained for females, and then they have some not for males, and then there are others who, if the older person becomes incontinent, both in bladder and bowel, there are some trained caregivers are not trained at that level. And this is very strict when you work in homes and assisted livings abroad, which is where I had done an internship. You could be a perfect model resident, but the moment you slip into incontinence the next day, you are moved to another facility because the caregivers at that home are not trained to deal with that. So if they keep you just because, well, you bonded well and all of that, they can get into trouble. So you have to move through the system based on your level of care need. And that will only kick in when we have new legislation to monitor homes. What do you see as in-demand skills in care for the future? What do you see as in demand? Is a host of things. I'm on my second to last question, by the way, so we did well. The demand skills that I see in the future will be IT, a simple thing. Some of our seniors don't mind it, that if we can have some intergenerational mix where with technology, they are less timid, and we have some younger people engage them and help them cross those little hurdles so that they can feel more independence. We need skills in geriatric care, because even Barbados they have a higher percentage than we have, but they have geriatric, they have a geriatric hospital, which we need. And so there are a host of skills that need to be in demand, such as even reading, like audiobooks. People can make audiobooks for some of our seniors, and how to engage them in discussion. If they are still, the memory is still good, and we have Meals on Wheels that they can go for those who are homebound. You don't have to let them be in an institution to get that. Based on your recommendations, how far have you all reached in achieving any of them? Well, some of them are still thoughts. I know you read the recommendation, that's why there are recommendations, but up to the time I was leaving, not very many were enacted, implemented, or in any way established, because we have to understand too that the whole aging question is very dynamic. And what is good now, because some of those recommendations might be redundant by now and may need something else for the new elder. And as I said, we have to ask the seniors themselves, what would they like? And, you know, and there are many things out there in terms of the transport, dial a ride. Yes, we have Eldamos, but we could also have better efficient escort service. And there are a host of services out there that still need to be driven. But this is where I will end by saying the advocacy for this group is vital. And so eventually I think I will boost TAP, which has its critical mass already, to now be more to the fore in terms of really advancing some of these policy initiatives and being a real force to be reckoned with in terms of coming forward to the government to lay their plan and say this is what they want to see. So I hope I did answer. Well, I got through all the questions that I had here. There were 13 of them. And thank you for the additional time that we did have, and we didn't do too badly. And I really enjoyed being here with all of you. And I hope that you have been encouraged to not just see the group as being a part, A-P-A-R-T, from you, but seeing yourself in them, so that whatever you may want to do or plan to do, plan it in such a way that you will be a beneficiary of what you're crafting. Because some of us right now may plant the seeds for trees that we may not get shade from, but we can see ourselves in the seniors that we serve and therefore serve them as you would like to be treated yourself. Thank you so much. Have a wonderful evening.